السلام عليكم ورحمة الله. كيف الحال يا شباب؟ عاملين ايه؟ النهاردة هنتكلم في تلخيص سريع كده للإيرلي بريست كانسر هرمون بوزيتيف HER2 نيجاتيف in the era of precision medicine risk assessment والبايوماركر تيستينج. هو تلخيص سريع كده للستاديز اللي يعني عملت دايركشن للديسيجن ميكينج في الفترة الأخيرة. بالنسبة لي الانترودكشن، طبعا بالنسبة لنا البريست كانسر هو يعني يعتبر ال second leading cause of cancer death in women, and approximately 70% of breast cancer are hormone positive HER2 negative. وزي ما احنا عارفين طبعا ان دلوقتي في البريست كانسر مانجمنت ما ينفعش ما يكونش عندك الهير2 والاي ار والبي ار. وبالنسبة للجين اكسبريشن والبراكا طبعا في حاجات معينة، لكن الجين اكسبريشن هنستخدمه زي ما قلنا في الهير2 نيجاتيف والهرمون بوزيتيف early breast cancer. Factors to consider for risk assessment and treatment guidance. انت عندك حاجتين، عندك الكلينيكال اللي كنا بنعتمد عليها زمان، وديت البيشنت ايج والهرمون والهيرتو ستاتس، التيومر سايز والجريد، الليمف نود انفولفمنت. لكن دخل معانا في البرسيجن ميديسن بعد كده الجين اكسبريشن والجينوميك تيست. هي منها بريدكتيف ومنها بروجنوستيك. البروجنوستيك معناها انك هتعرف والله المريض دوت يعني او this disease how it will يعني proceed او how it will يعني what is the fate او natural history او natural course بتاع disease دوت. لكن predictive you can decide upon the result from this genomic testing. Several commercial available gene assays are there, but the only one who seems to be predictive is the oncotype DX. طيب how developed oncotype DX؟ oncotype DX مر بثلاث مراحل. هي الاستادي الأولى كانت ال NSAPP B14، وديت كانت بتحدد البروجنوزس of disease compared tamoxifen بالكيموثيرابي. وفي المرحلة ديت يعني قدروا يحددوا ان الأونكوتايب دي اكس كان بي prognostic marker. لذلك هم initiated ال NSA PPB20، وديت عشان كانت أول initiation لل predictive ability of oncotype DX، واللي discovered فيها ان ال patient with high recurrence score يعني 31 or above this patient has absolute benefit from tamoxifen plus chemotherapy. فده اللي خلاهم بعد كده يعني يinitiate ال TELOREX landmark practice changing trial. That's the NSAPP-B20 trial establishes that patient with recurrence score from 0 to 10 does not benefit from addition of chemotherapy to endocrine therapy. وعلى الجانب الثاني recurrence score from 26 to 100 do benefit from chemotherapy. So there is a hazy area from recurrence score 11 to 25. So that's why they initiated this TELOREX study design. They randomized those patients with node negative and hormonal positive and the tumor size from this window, and for tumor size of this window and high grade they randomized this recurrence score window to endocrine therapy alone or endocrine therapy plus chemotherapy. Telerex proved that patients with recurrence score result from 11 to 25 do not benefit from chemotherapy, and the invasive disease-free survival between the two arms was almost identical. And the secondary endpoint also for distant recurrent-free survival and secondary point for overall survival also it was identical. That's why clinical evidence from Telerex and SAPPP20 studies establish that the oncotype DX can be predictive for this patient who can be spared from chemotherapy. From 0 to 25 can be spared, and from 26 to 100 should receive chemotherapy. And the age factor was the only factor that found to have a correlation with the treatment response. That's why the result was modified for above 50, that no chemotherapy benefit for the all window from 0 to 25 recurrence score, and less than 50 or equal can benefit from chemotherapy in the window from 16 to 25. That's why in the premenopausal population or patients, NCCN recommended that this window from 16 to 25 it is better to offer chemotherapy in this window. And also for the postmenopause, they recommended for all patients to have this oncotype DX. For node negative patients and the recurrence score is less than 26 can benefit from the endocrine only, and for recurrence score more than 26 this can benefit from chemotherapy than endocrine therapy. Also in the ASCO guidelines in 2022 they offered this option and recommended for oncotype DX in the premenopausal woman, node negative oncotype DX, and postmenopausal node negative oncotype DX, and postmenopausal in 1 to 3 node positive, based on the coming trial RX Ponder. What about node positive? Node positive patients were assessed before in the SWOG trial 8814. Prognostic and predictive value of breast recurrence score test for node positive disease. This study showed that the statistical significant area or window is between 18 to 30 recurrence score, where there was identical almost results between the two arms of chemo, endocrine and endocrine therapy in this all window. That's why RX Ponder was initiated to refine this window between 0 to 25. So it was randomized between chemotherapy and endocrine therapy, those patients with node positive 1 to 3 lymph node positive, and the results, as you see, in the postmenopausal population, endocrine and chemo endocrine were identical, and in the premenopausal there was a clear difference between the two arms. Invasive disease-free survival was the primary endpoint. Here in the post-menopausal, almost identical, and in distant recurrent-free survival also almost identical. And in this forest plot, there was no difference between the chemoendocrine and the endocrine arm in the postmenopausal woman, while in the premenopausal woman there was a clear difference between the two arms in invasive disease-free survival and the distant recurrence-free survival. And in the forest plot, as you see here, in the subgroup analysis, almost all subgroups in favor of chemoendocrine arm, except here for above 50, as we mentioned before, and low risk patients, as we mentioned before. That's why in ASCO they recommended this Oncotype DX, as we mentioned, for postmenopausal in node positive and negative, premenopausal in node negative only. And as per NCCN, the Oncotype DX is prognostic and predictive, while the other commercial tests like MammaPrint, like BCI, like EndoPredict, they are only prognostic and there is no predictive value here. What should we give instead of chemo? So we spared patient from chemo. What is the endocrine therapy we can offer? This can be answered by the past studies, as we saw that they integrated in the randomization tamoxifen, and according to EBCTCG study, benefit for tamoxifen versus placebo, it added a reduction in risk of recurrence 50%, reduction in risk of breast cancer mortality 28%, reduction in risk of contralateral breast cancer by 47%. This tamoxifen versus placebo. Here you should stratify your patient to premenopause and postmenopause. For the premenopause choice, they conducted a very good study that will assess the ovarian suppression, because the studies in the premenopausal patient of ovarian ablation or suppression alone versus CMF chemotherapy protocol generally demonstrated similar anti-tumor efficacy. So this ovarian suppression can add on benefit to our patient, so they conducted these two studies, famous studies, soft and text trial, suppression of ovarian function trial, and tamoxifen and exemestane trial. And it was conducted, as we mentioned, for premenopausal woman breast cancer in the adjuvant hormonal therapy with ovarian function suppression. And two questions were to be answered. Does this add any benefit with aromatase inhibitor with ovarian function suppression, and aromatase and tamoxifen with ovarian function suppression? Soft and text trials, they are randomized phase 3 trials initiated in the 2003, and the randomization for the soft trial, 3 arms: tamoxifen alone, tamoxifen ovarian suppression, exemestane ovarian suppression, and in the text, tamoxifen ovarian suppression and exemestane ovarian suppression, and combined analysis between tamoxifen ovarian function suppression and exemestane ovarian suppression. The inclusion criteria of our patients, they received chemotherapy by 53%, HER2 negative 85%, node positive 35%, and in the text chemotherapy received 60%. For those patients, the primary endpoint was the disease-free survival, which was analyzed by the 8 years, and it showed statistical significance in the exemestane ovarian suppression and tamoxifen ovarian suppression compared to tamoxifen alone. And in the subgroup analysis, the chemotherapy group who received chemotherapy group had much benefit than other group who did not receive chemotherapy. The secondary endpoint was overall survival in this study, and it showed a statistical significance between tamoxifen and tamoxifen plus ovarian suppression, and no statistical significance in the exemestane ovarian suppression. Secondary endpoint also freedom from distant recurrence. It was in favor of exemestane ovarian suppression. Combined analysis between two studies showed disease-free survival in favor of exemestane ovarian suppression, and overall survival wasn't statistically significant. Freedom from distal recurrence was in favor of exemestane ovarian suppression. So exemestane ovarian suppression was to be prescribed for high-risk patients who received chemotherapy before, who was not positive, and according to ASCO, you can judge those high-risk patients according to age, number of positive lymph nodes, tumor size, ERBR status, tumor grade, and Ki-67. To summarize this soft and text, this premenopausal woman can be offered tamoxifen with ovarian suppression and exemestane with ovarian suppression according to high risk features. NCCN recommends this ovarian suppression plus aromatase inhibitor in young women, high grade tumor lymph node involvement, and this strong evidence will increase, or indication will increase if the patient had received chemotherapy before. What about postmenopausal women? Postmenopausal women, we can spare her from chemotherapy, but what kind of endocrine therapy we can offer? Aromatase inhibitors, several studies have evaluated aromatase inhibitors in the postmenopausal woman. One of them is ATTACK trial. ATTACK trial compared anastrozole, tamoxifen, and combination of both. And this was randomization 1:1 for 5 years with regular follow-up. The primary endpoint was disease-free survival, safety and tolerability. Secondary endpoint was incidence of contralateral breast, time to distant recurrence, overall survival, time to breast cancer death. What is the result in those graphs? After about 5 to 6 years of follow-up, anastrozole and tamoxifen showed a reasonable and differentiation between results, which was significant statistical in the disease-free survival, and also in recurrence there was a difference, but in the overall survival wasn't statistical significant. But where is the third arm, combination? Combination arm was deleted or stopped due to the increased toxicity with no benefit. So the ATTACK trial analysis showed reduction in risk of recurrence 26%, reduction in risk of breast mortality 13%, reduction in risk of contralateral breast 52%. So based on this trial, as we mentioned, also the absolute difference between anastrozole and tamoxifen continue to increase over time and extend beyond completion. This we are telling that there is a carry-on effect. Carry-on effect after stoppage of the treatment, it continues to benefit the patient, and expected overall survival is similar for both arms. So combination has no benefit. A rising question is there a benefit for sequential hormonal treatment? This big 198 trial can answer this question because the randomization for postmenopausal women was to 4 arms: A, B, C, D. A, tamoxifen, letrozole. B, C, tamoxifen followed by letrozole. D, letrozole followed by tamoxifen over 5 years. And the primary analysis after for disease-free survival primary analysis showed very strong statistical significance for letrozole arm. That's why they, according to ethical guides, they unblinded this trial, and they offered for the tamoxifen arm patient to be shifted to letrozole, and for the secondary endpoint, overall survival was met for the letrozole arm, and for disease-free survival for other arms it wasn't statistical significant. But for how long can we offer this hormonal treatment? To answer this question, Atlas trial was investigating tamoxifen 5 years versus 10 years, and it showed that 10 years is statistically significant. There is statistically significant benefit for tamoxifen over 10 years, and there is carry-on or carry-over effect of tamoxifen even after stoppage for 15 years. Here the recurrence rate for 10 years, it was 14 versus 13, and the recurrence rate after 15 years in the arm of the tamoxifen 5 years, it was 25, and it was in the arm of tamoxifen 10 years, it was 21. So this is the carry-on effect. Also in the mortality, the mortality was lower by almost 3% in the 10 years arm, and the breast cancer recurrence was the lowest value was with the 10 years tamoxifen, and the lowest value also in the breast cancer mortality was in the 10 years tamoxifen. This is for 10 years tamoxifen. So what about 5 years tamoxifen followed by 5 years of letrozole? This also was conducted in the MAE17 trial, phase 3 randomized double-blinded postmenopausal women. They received 5 years of tamoxifen and randomized to letrozole versus placebo. Primary endpoint disease-free survival also, and secondary endpoints overall survival, distant disease-free survival, long-term safety, quality of life. And after a while, 2.5 years, the risk reduction in the risk of recurrence, it was 43%. That's why again the study was unblinded, and they offered the control arm to have this letrozole, and the primary endpoint after about 50 months disease-free survival showed statistical significant and reduction in risk of recurrence about 42%. The distant disease-free survival is more meaningful endpoint than overall disease-free survival, as distant disease-free survival translated into longer overall survival. Also, we have here the BCI. The BCI is the genetic expression assay that can give us a prognosis that can guide us who can benefit from the extended hormonal therapy or no. For a patient with low risk for BCI, this can be spared from longer duration of hormonal treatment, while in the high score of BCI, this arm can have benefit from extended hormonal therapy. NCCN panel find that no evidence was there in the efficacy or toxicity difference between aromatase inhibitors. You can use anastrozole, letrozole, exemestane if you want to use this arm aromatase inhibitor. And take home message from this NCCN guidelines: for post-menopausal patient, aromatase inhibitor as initial adjuvant therapy for 5 years, this is category 1, you can use it. If you will use tamoxifen for 2 to 3 years, aromatase inhibitor to complete 5 years, this is category 1. Another 5 years of aromatase inhibitor, category 2B. Another 4.5 to 6 years followed by 5 years of aromatase inhibitor, category 1, or consider tamoxifen up to 10 years. Postmenopausal patients, the use of tamoxifen alone for 5 years, category 1, or up to 10 years is limited to those who decline or who have contraindication to aromatase inhibitor. For premenopause, 5 years, category 1, with or without ovarian suppression. Ovarian suppression plus aromatase inhibitor for 5 years, also category 1. After 5 years of initial endocrine therapy, if the patient develop postmenopausal status, NCCN recommend considering extending therapy with aromatase inhibitor for up to another 5 years. This is category 1 also. And based on data from Atlas trial, considering tamoxifen for another additional 5 years if used as initial 5 years. For those who remain premenopause after the initial 5 years of tamoxifen, 10 years of tamoxifen is a reasonable option also. All these options are there to show you that if there is any appearing side effect, can be avoided by transforming the patient or shifting the patient from tamoxifen to AI or vice versa. And thank you.